Hi, I'm Chandu. I'm a specialty doctor in orthogeriatrics, and I will briefly highlight some things. And most of the things my colleagues already talked. I will tell what we usually do as orthogeriatricians. We see patients about 60, and especially neck of femur fracture patients, we review them within 72 hours of admission. That is our main target. And also we see these patients pre-op and also once they are post-op as well. And after that, after we implement a plan, it will be the orthopedic junior doctors who will continually follow up these patients. And if you have any concerns afterwards, you can always come for us for help. And also, when you clerk patients initially, remember to include investigations like the false bloods. When you do, I know you do the full blood count and the basic investigations, but remember to include the false blood, which are the vitamin D, TSH, folate, and B12 as well. So that the following day they will be available, and when we review the patient, we can take certain decisions. And apart from that, I think most of the things my colleagues already spoke. So yeah, I will conclude. Thank you.
Hi, I'm Minfaz, one of the specialty grade doctor in orthogeriatrics. Let's have a quick chat about how you can work in our department. Whenever you see a patient, it's very important to do preoperative and postoperative investigations like full blood count, CRP, kidney function test, liver function test, clotting profile, and along with other necessary investigation. Whenever you order these investigations, if you find any problem and we need to act upon it, like if we find low hemoglobin, either we are going to optimize hemoglobin or else we are going to do anything else depending on the abnormal investigation findings. And it is very important to review these preoperative and postoperative investigation findings with regard to the investigations that we have ordered. And postoperatively, it is very important to pick up the abnormal findings like any electrolyte abnormalities. Most of these patients may go into AKI. In that case, you need to act upon. And at the same time, if you find any difficulties managing these patients, you can come back to us and get our help. And next thing I would like to tell you, whenever you have a problem, it is very important to present the case to us. For an example, if you suspect something going inside the lung and patient is having cough, and on top of that the patient is having fever, your possible first differential diagnosis will be pneumonia. You can present possibly maybe something going with the lungs, maybe a pneumonia, and then we have a background knowledge about what we need to do. And I'll give you another example. If the patient has leg edema and if the patient was previously diagnosed patient with heart failure, it may be some worsening feature of a heart failure. You can give me some background information with regarding to what's going on. It will be very easy for us to prioritize the patient, and it will enable us to make our patient safe as well. And next very important thing what I wanted to mention, whenever we are implementing any specific plan with regarding to our patients in the orthopedic, like any bone protection, please try to include these plans to the discharge plan. And that's what I'm going to share with you all. Thank you very much.
Hello guys, my name is Anthony James. I am one of the ACPs in Orthogeri team. Orthogeri team consists of 2 consultants, 2 specialty doctors, and 2 senior Orthogeri visiting registrars. So we cover Monday to Friday, and weekends there is no orthogeries, but bank holiday weekends we cover normally between us. So that is our team. I thought I'll introduce myself and my team. I'm sure the other team members will be speaking to you as well. So this is our booklet regarding the clerking. So some sort of missing points in the practical way I thought I'll explain. So all the femoral fracture patients, age 60 and above has to have this booklet. So that is one of the clerking point for you. And all the papers, it is very straightforward care pathway, integrated care pathway booklet. So first you will see the AMTS, so that is must, you must fill that one. Sometimes in a rush we may forget, but you must fill, all the patients should have a AMTS score. And history, and it is very good booklet, so everything is in a nice organized way, it is explained. And drug history is there, and this is the page where we are involved. Orthogeric review is there, so any plans, if you want to go back and see, this is where you need to look at. And all the investigations, we are briefly explained everything, so you can have a look at about this booklet. And the other things I wanted to mention about EPMA, when you clerk the patient, you need to admit obviously into the EPMA, and pain pack is the one of the useful tool you need to remember. When you click that one, if you search in EPMA pain pack, then you will find that pack. With that pack includes all the necessary painkillers, and the laxatives are there, so you don't need to individually go and prescribe. So you just click and then click a button, that will be there. And I am sure my colleagues will speak to you as well about their point.
I just wanted to mention a couple of resources that we often use, especially when you're on call, that can help answer some questions. So Sanjay previously mentioned Orthobullets, and I would second that being a fantastic resource. There's the Ortho SHO website. If you just Google Ortho SHO, that will come up and be shown to you, as well as an app, which I think you can get on Google and on the App Store, called Ortho Flow, which allows you to select which bone is broken and how you then subsequently go about investigating and managing such a fracture. It can just makes your clerking and admission much smoother and more thorough.
So VT prophylaxis is really important for all patients in hospitals, but especially orthopaedic patients. Patients with fractures, patients who have joints replaced, they get PEs and they get DVTs if you don't give them DVT prophylaxis. So here at enoxaparin, there's a protocol available which tells you all the doses for different weights, and it's just something to check on ward round and make sure everybody's got it unless there's an absolute contraindication.
Ward 22 is the elective ward, so if you have been posted in Ward 22, then you're expected to, not to clerk the patient, because the patient would have been clerked and all the medications would have been prescribed in the pre-op assessment clinic. So you're expected to order the post-operative investigations for this patient, including the blood investigations and radiographs, and also to prepare the discharge summary for the patient. So when the patient come in for the surgery, they have the elective surgeries and they come to Ward 22. So you need to make sure that all the patients who had the surgery today need to have the post-operative bloods and x-rays for tomorrow, and you need to review it the next day. And also most of the patients having elective surgeries, they won't be having multiple comorbidities like the traumatic patients. So you need to start having an idea of prepping the discharge summary as soon as possible, because the patients can complete the physiotherapy and the patient won't need occupational therapy in many cases. So I feel when the post-op bloods and post-op x-rays look fine, then you need to start the discharge summaries of the respective patients, and also look at the post-operative images to have a general idea of how well the implant is fitted, and to see if there is any abnormalities with the x-rays at all. That will give us reinforce the anatomy, and also will be good to learn. Interesting.
So thank you very much, Sanjay, Alex and Alex, for helping us with this video. Can I just ask you, what is the most daunting task or time of the day during your day on call in orthopedics?
Anyone want to start? For me, it's when you have multiple referrals up in the air at the same time. So you'll have patients that need to be admitted, as well as from A&E majors, as well as patients in A&E minors who might not or might need admission, and juggling that caseload can be a bit stressful.
So how do you prioritize that?
So I prioritise it based on sort of clinical severity, really. I think if the assumption to make is if a patient requires admission, they are the priority, and so I'd be trying to tie up my admissions first. and then go on to see the more minor injuries, which often can be managed out in the community.
So what is the commonest referral you receive when you're on call from the A&E?
Neck and femur fractures.
Yeah.
Neck and femur fractures, okay. So the A&E calls you and they say they've got a broken hip for you. So what's your remit then? What do you have to do? Alex?
So the first thing is to go and see the patient and clerk them. So here we use a special yellow clerking book for all femoral fractures, so not just neck and femur fractures, all femur fractures. And then you just clerk the patient as you normally would. Specific things to note is you need to do an AMTS score on them. You need to take a detailed social history about their mobility status pre-injury, about their package of care, and about their general life at home, because that might dictate management. Then when you're examining, you obviously need to make sure their neurovascular status is all right, and then pay particular attention to things that you might find in the sort of more elderly population, so things like blood thinners that would need to be stopped, for example.
And these are all protocol based when to stop the blood thinners?
Yes, there's all protocols available for them.
Okay. And how much time do you think normally it takes for you to clerk a neck or femur patient in A&E?
Probably just
Start to finish?
Probably just under an hour, to be honest.
Okay, and then when you clerk the patient, do you have to do anything else with the details of the patient at all?
So if you feel competent to do so, you can consent and mark the patient. And then you need to make sure they've got all the appropriate imaging ready for the next day's trauma meeting. So often just an X-ray pelvis will be enough, but often also they'll need a CT as well.
So do you maintain a database at all?
Yes, I think Mr. Garvey's trying to get at the paper handover that I would suggest all on-call doctors try and keep as up to date as they possibly can throughout the day. Don't just leave it to the end of the day, constantly update it, especially with things like patient location and imaging results, because that can help you and your seniors keep track of where patients are.
So how do you access that handbook and handover, sorry?
So the handbook is on the shared Z drive. So it's Z drive under weekend handover, and then in the trauma and orthopaedics folder, there'll be an on-call folder within trauma and orthopaedics, and then it's just stratified based on year, month, and week. So you just click through. So you just click through to the appropriate handover. The password is also handover lowercase h.
Fantastic. And how do you navigate your way through some difficult, challenging cases in A&E and you feel out of depth, Sanjay?
So whenever I get a difficult case or whenever I get a referral which I'm not sure of, what I'll do is I'll look at the detailed history and to see what I have missed, or if there's anything really complex about this patient. Then I'll use the Orthobullets website to see if they have anything that could help me in assessing this patient, or if that could fill any gaps in my knowledge. If that doesn't really help me, then there's always a registrar on call, middle grade, whether it's day or night on call, it doesn't matter. So if we discuss the patient with a middle grade, so they'll be able to direct us in the right way and manage the patient appropriately.
How would you manage or navigate your way through a referral for septic arthritis, potential septic arthritis of the knee, Alex?
Which Alex? Me. First thing I want, straight off the bat, first thing I want to know whether it's a native or prosthetic knee, as that will dictate if a patient needs an aspiration, where is the most appropriate place to do that. It's a contraindication towards doing a joint arthrocentesis in anywhere apart from a sterile environment if they've got a prosthetic knee in. So you need to know that straight away. Next thing I'd like to know is a bit more background from the patient. So kind of a nice history, time of onset, associated examination findings, limitation, range of motion, difficulty weight bearing, these kind of things, swelling, erythema, etc. I would then be wanting to know their past medical background and looking for risk factors, so things such as long-term steroid usage, diabetes mellitus, or any form of immunocompromise, preceding injuries, specifically things like penetrating injuries in and around the knee and soft tissues. I then want the ED to have already organised orthogonal views of the knee, so an AP and lateral of the knee to rule out occult injury, occult fracture, but as also as it can help me plan my point of arthrocentesis if you're able to see which particular areas of the knee are fused or if there is a fusion in the first place. Once I've got that history and I'm sure that those images are in place, I'll then check their bloods. I'll be looking for raised inflammatory markers as well as urate, and then having a look at their past drug history to see if they've ever been on things such as colchicine or I've just completely forgotten. Not colchicine. What else do you use in gout? Allopurinol. Allopurinol. Apologies. Then I'll go on to examine the patient. Septic knees can be quite subtle and they can mimic a lot of other pathology in the knee, so you should always have a high incidence of suspicion for it. You'll be wanting to take them through active and passive range of motions of the knee. You'll be wanting to palpate for effusions, patellar taps. You'll be wanting to feel for any obvious heat coming off it, and as well as checking for erythema. Sometimes lower limb cellulitis can be inappropriately referred as septic arthritis, and therefore it's always a good idea to fully expose the entire limb to see if there is a rash, where this rash is extending to or from. And then finally, once you're happy that there is a chance of there being septic arthritis, I'll be preparing for a knee arthrocentesis. I can talk through the procedure if you want or not, but once you've got your knee arthrocentesis, which you can do as a junior, but if you aren't confident, call your registrar. It's important that those are taken into the universal top bottles and then are sent off urgently to the Norwich lab. They don't get done here, they get sent to Norwich for an urgent gram staining and crystal assessment. That should come back within about 6 hours from time of receiving a lab.
Thank you. For the patients you send home from A&E, what process do you follow? How do you make sure that the patients are seen back in the fracture clinic? For example, a kiddie with a fracture and you've given them a back slab or something like that.
Sure, so the first thing to identify is when you want to see them back at fracture clinic. It might be a couple of days, it might be a week, month, 2 weeks, etc. Once you've established that, you go and speak to the A&E front desk reception and ask them, they will book the patient into fracture clinic for you, and then you can give the patient their date and time there and then, so you know it's all in place basically.
Thank you. How do you make sure that the EPMA is correctly filled in, Sanjay?
So if the patient is conscious oriented, if the EMTS is done out, and then you can ask the patient what medications the patient was taking. If just to double check, I will refer it to the NHS Spine portal, where usually all the updated medications, whichever the medications have been added recently, everything will be there, including the dosages and the frequency of the medications the patient is taking. I will also refer to the recent electronic discharge letter, because that would contain all the medications. I'll refer to the NHS portal, e-discharge, and ask the patient him or herself, so that I'm double sure of all the medications, so that I don't miss anything at all.
Thank you.
Admission.
Alex, do you guys have to deal with the respect form at all?
Yes, we do.
And how do you go about that?
So yeah, all patients, regardless of their reason for admission, need to have a discussion around their resuscitation status, which is then appropriately documented in the respect form. That is best had at the sort of point of admission, and if the patient themselves has full capacity, then I'll be having that discussion with them directly, and making a sort of a clinical based judgment of what I feel to be appropriate for them, and then having that discussion with the respective patient. However, it's quite common that, especially some of our more elderly patients, have underlying cognitive impairment, which would make them not have capacities to make a decision around that, and therefore it's very important that you're contacting the next of kin to discuss that with them at the point of admission. It's also a good idea, whilst you have them on the phone, to ask them further questions in your history, such as their social background, performance status, etc.
Thank you. Alex, how much help do you think is around when you're on call or in the wards? And just be honest, and do you think you're many times out of depth and you think that I'm left alone, or do you have ample help from medical colleagues and orthopedic colleagues?
Yeah, no, so I've always found everyone very accessible. So during the day, so from 8 AM to about 6 PM, both the consultant on call and the registrar on call are around on site and very accessible and easy to find, usually either in fracture clinic or in theatre. After about 6 p.m, the registrar on call is non-resident, but they're carrying the mobile, they're accessible through switch, and they're always very easy to get hold of for advice over the phone. And if you need them to come in, they'll come in. So I haven't had any problems with it.
What about the medical problems?
Yeah, so for the medical problems again, so during the day, sort of 9 to 5 kind of time, we've got our orthogeriatrics team to ask about medical problems. Outside of those hours, there's the medical registrar to ask, and again, I think they all seem quite happy to help with medical problems on the orthopaedic wards.
Thank you, three of you. Thank you very much. One rolling.
Okay, so now I'm going to talk about the night on call. As suggested, it starts at 8 o'clock in the evening, and you take a handover from the day SHO. That handover should include the admissions the day SHO has made and any jobs that they will need going forward into the night, as well as any potential sick patients that have been handed over to the day SHO from our ward teams to make you aware of. The other thing, there might be also outstanding referrals from A&E for which you'll have to prioritise. Once the handover has been completed, you'll be given the bleep, which I should mention is 2029, but you won't forget it by the time you've done an on-call shift. And you start by completing the jobs from handover and then fielding any referrals from A&E. I try and structure my night around visiting the wards at the beginning of the night to nip in the bud any jobs such as fluid prescriptions, post-operative antibiotics, VT prophylaxis, these kind of things, and it's easy just to get them all tied up and out of the way at the beginning before you're busy with referrals.
Rolling 3 to 1.
So your shifts on call will be sent out to you by our rota coordinator, and they tend to be in the patterns of 4 shifts in a row and 3 shifts in a row. The 4 shifts from Monday to Thursday and the 3 shifts from Friday through to Sunday. The day shift starts at 8 in the morning with the trauma meeting, which occurs in our education and training centre, and finishes at 8:30 in the evening with a handover that aims to start at 8 o'clock. That handover often occurs either in the mess or in the canteen, and that's led by the junior doctors. As I said, whereas the night shifts start, as suggested, at 8 o'clock in the evening and then finish again at 8:30 in the morning. Your day starts with a trauma meeting, and this is a meeting where all cases admitted from the day previously, both overnight and during the day, are presented and discussed with plans put in place. All cases who've gone to theatre are discussed with any appropriate post-operative images reviewed, and any further referrals, be it from inpatient wards, GPs or from A&E, are discussed as well. The meeting is often led by the night SHO, as they're the ones who get there first and set up the computers, but is then taken over, and discussions between the senior consultants then take on from there. Once your trauma meeting is completed, you then go on to the post-take ward round, and the post-take ward round lasts from about 8:30 till about 10 o'clock, where you see all of those new admissions that were discussed in the meeting, as well as any appropriate post-operative patients. Decisions about their ongoing management are made, and it's important that you clarify things such as post-op blood results, post-op x-ray requests, length of antibiotics, weight-bearing statuses, patients' VTE prophylaxis, and any plans for follow-up with the orthopaedic department. Once that ward round is finished, you'll split off from your registrar and your consultant. Your registrar and consultant will go to the fracture clinic, and that lasts from about 10:30 till 1, which is where you'll find them if you need advice. And then you are left to finish jobs from the post-take ward round and start fielding referrals from accident emergency.
Rolling.
Hi, good afternoon. My name is Dr. Alexander Curran. I've been a SHO within the orthopaedic departments for the last, coming up to a year now, both across my F2 and F3 years. And I plan to talk to you about a day on call and a night on call as an orthopaedic SHO.
1 rolling.
So there's good opportunity here for audit and research. I myself have been able to become involved in a few sort of national audits, just taking part of the data collection and things like that. Fortunately for orthopaedics, there's lots of that kind of research and audit going on a national level, so that's quite easy to get involved with. Yes.
3 to 1 rolling.
So yeah, today I'm going to explain what you are expected to do on a normal non-on-call working day that's in the ward. Either it's in Ward 6 or Ward 22. Ward 6 is a trauma ward and Ward 22 is a elective ward, but that can vary depending on the caseload. So your day usually starts with attending a trauma meeting at 8 o'clock. So this is where all the patients that have been admitted or any difficult patient that needs to be discussed are discussed. with a multidisciplinary team here with consultants and anesthetists as well. So you can attend this trauma meeting that happens in the PGME educational center, or it can be attended virtually as well, but I would recommend attending it physically because you can clarify whatever doubts or queries, and you can learn a lot of things reading the radiographs and managing the patients there. So you can attend it by Teams as well virtually, as I said before. Your day would start with attending the trauma meeting, then going to either Ward 6 or Ward 22, whichever you have been allocated to. So in Ward, what you are expected is to medically manage the orthopedic patients. So the patients who have been admitted with a fracture, basically due to trauma, have a lot of comorbidities, elderly, frail patients. So you would want to make sure that you are preparing this patient for the surgery if that patient has been admitted very recently. So you need to make sure all the medications and all the basic blood investigations, group and save, everything is arranged for this patient, and also the adjuncts, like sometimes some patients might need CT or CT chest, abdomen, pelvis. You need to plan it accordingly. You need to make sure that this shouldn't delay the surgery, and you need to plan it accordingly. Coming to the post-operative period, in post-operative phase in the Ward 6 traumatic ward. So you need to book the basic post-operative blood investigations and post-operative x-rays if at all that's indicated. You need to refer to the operative notes in order to follow the mobility status of the patient, and also antibiotics and basic instructions which are needed for this patient. And you need to assess the patient if the patient is medically optimized for discharge, and arrange the follow-up as well.
3, 2, 1, rolling.
So as a core surgical trainee, there's of course a few ward commitments as well. So I'd be expected to ward round and see patients that come in on the trauma take. One of the big cohorts of patients we get here are elderly patients with usually neck or femur fractures, and because that's a very significant trauma to them, and because they're often elderly, frail, and have many medical comorbidities, it takes a lot of sort of medical care to optimise them for surgery, and also to make sure they're okay after a big operation. So to help with that, we've got the orthogeriatrics team here who are here almost every day on the weekdays, and they'll see all the new additions and help with the sort of medical problems for these patients. Yeah.
3, 2, 1, rolling.
So the East of England Deanery expects of us, from an operating point of view for a core surgical trainee, to get about 150 cases in the year. And also perform a few mandatory docs, like for example scrubbing, performing an incision, or closing an incision. That is all very, very possible on this job. So my sort of an average day for me would be, I'd go to the trauma meeting at 8 o'clock, which will tell me the cases that are coming up on the trauma list that day, and it'll have some interesting discussion that's very useful for learning as well. After that, at about 9 o'clock, I'll normally go straight to trauma theatres, where there'll be a few cases, and that's where you can maximise being able to do the cases that you might be able to do a few bits and pieces of, like DHSs, for example. That goes on till about lunchtime, and then in the afternoon, if the wards are busy, I would do some ward work. If there's plenty of other juniors around the ward, then I can continue in theatre. And there's a choice of, you can continue in the trauma theatre, or you could go to an elective list, depending on your preference.
Yeah, today I'm going to talk about how to do a pre-op assessment clinic. So basically you'll be expected to take a brief clinical history, complete the pre-op questionnaire, and do the physical examination, order necessary investigations, and do the EPMA charting for the patient. So if you're not on call, then you'll be posted in wards, either Ward 6 or Ward 22. So if you're in Ward 22, you might be posted to pre-op assessment clinics from morning 10 o'clock. It can vary depending on the patient load, but it starts at 10 o'clock. So you'll do your basic ward duties from morning 8 o'clock till 10 o'clock. From 10 o'clock, you need to be in pre-op assessment clinic. So when you're called to the pre-op assessment clinic, you need to go there, take a brief history from the patient. So what you need to ask is, why the patient is scheduled for this surgery, what was the indication, and the clinical symptoms which the patient is having, and also you need to make sure the consenting is done, and also make sure which side the patient is getting operated on. So that's the most important aspects in clinical history you need to confirm. After getting a brief clinical history, you need to complete the pre-op questionnaire. So pre-op questionnaire is a questionnaire which covers all the systems in the body, like let's say cardiovascular system. Cardiovascular fitness is extremely essential, which predicts the post-operative recovery of the patient. So there are questions where there is exertional chest pain, and questions like any unusual palpitations which you need to complete in the questionnaire. So and basically respiratory system questionnaire, like patient is having any chronic cough, any smoking history, that you need to tick in the pre-op questionnaire. So it goes like this. It goes a series of around 12 to 15 questions which you need to tick it off. So after doing that, then you need to examine the patient yourself, assess the range of movements, because when the patient gets a knee replacement or hip replacement, the range of movements will be significantly improved. So you will have a baseline data. The patient had this range of movements after surgery. It is significantly improved. So yeah, that will be a good thing to notice. And yeah, then you have to chart all the drugs the patient was taking, stop the necessary the medications which you think are not appropriate. So like warfarin, edoxaban, you need to stop it, and if at all you feel the reversal agent needs to be started, then you need to start. So this is how a pre-op assessment clinic goes in a normal day.
Hi, my name's Alex. I'm one of the orthopaedics themed core surgical trainees here at James Paget, and I'll be speaking a bit about the experience of a core surgical trainee here, and also a little bit about our orthogeriatric team.
Hi, I'm Sanjay. I'm one of the foundation year 3 doctors in orthopedics. First of all, welcome to orthopedics. It's been a nice experience for me for the past 8 months. Today I'll be talking about how to do pre-op assessment clinic, and also how to do your duties and responsibilities in a normal non-on-call ward work. So I'll be talking about both in this video today.
Good morning, my name's Adam Michael Cohen. I'm one of the consultant orthopaedic surgeons here. I'm a specialist in hip surgery. I'm also the National Hip Fracture Database lead for this hospital, which is obviously very important to us. From the juniors' point of view, I expect them to look after our patients well on the wards and to see them on a daily basis. Some of the most important people to see are the hip fracture patients, and that is obviously my main interest.